And now we will culminate today with our final conversation, translating talk into action, with Dr. Kellan Baker of the Whitman Walker Institute and Dr. Reggie Tucker-Seeley of Zero, the End of Prostate Cancer, where they will engage in a dynamic conversation about the various takeaways from today, and more importantly, how we can use that to take action.
Well, thank you so much for the invitation to contribute to a summarizing or closing conversation for this amazing event. Our goals for this event include that we hope you will all leave here today with a better understanding of our country's history, of why we see the health and healthcare disparities present today, especially racial disparities, given what our esteemed keynote speaker, Isabel Wilkerson, spoke about today. And I hope that for those of you who haven't read her book, Caste, that her presentation encourages you to do so. I know that we also hope that you will leave this event understanding what it is like for people who might not share your same identity to navigate our public health and healthcare delivery systems. And lastly, I hope you all leave this event today feeling like you have some action steps, even if small steps. And I think, though not small, even a commitment to radical empathy is one thing that we can all start doing immediately. Three themes that I do want to highlight that will contribute to the conversation that Dr. Baker and I are about to have is this notion that oftentimes efforts to eliminate health disparities focus on educating the patient. But I heard a speaker once who was talking about racial disparities and maternal mortality say that a bad system will beat a well-informed or educated person every time. So efforts focused just on educating the individual won't be sufficient. We need to work on asking the question, what does an equitable healthcare delivery system look like, and how can we create that? I realize I just said cancer just because that's always the question I ask in my cancer care delivery work. Since the summer of 2020, there have also been many more organizations stating that they want to focus on disparities reduction, elimination, and health equity. However, it is very important that organizations do the internal work to ensure organizational readiness in terms of ensuring that employees are, practicing radical empathy and prepared to work with communities experiencing disparities. Also, in this space, we often want to get to solutions too quickly. Yes, we want action, but we must be clear about what we are acting on. And as much as we can, we need to explicate the pathway of the mechanisms where we want to intervene. And there must be an explicit recognition of past wrongs. And this truth and reconciliation effort is critical to really showing that an organization is trustworthy. And lastly, in my current role, I'm the Vice President of Health Equity at Zero, the End of Prostate Cancer. And we do a lot of work out in the prostate cancer community, specifically focused in my role on the disparities that Black men experience as they're navigating their prostate cancer journey. I had an amazing colleague in the community call me and my team in to remind us that we don't always have to talk about communities that experience disparities from a deficit perspective, and to make sure that we also focus on strengths and assets. That is, when those of us working on disparities elimination and health equity, that we come to communities not only to highlight the disparities, but we also work with those communities to further amplify their strengths. Now, of course, this wasn't the first time I've heard this, but it was a great reminder, especially for those of us who trained in public health where racial and ethnic minorities are consistently presented as doing worse than their white counterparts for most health outcomes. I look forward to continuing this conversation, and now I'll turn it over to Dr. Baker.
Thank you, Dr. Tucker-Seeley, and everyone for being here today. It's such an incredible honor to be in company like this, to hear these conversations, in particular the incredible highlights from the conversation with Isabel Wilkerson this morning. I am the executive director of the Whitman Walker Institute, which is the research, policy, and education arm of Whitman Walker. We're a community health system in Washington, D.C. that also includes a federally qualified health center. And we have 50 years of experience working to serve diverse communities across the DC area, with a particular focus on LGBTQI+ patients, that's lesbian, gay, bisexual, transgender, queer, and intersex, and people living with HIV. And we're very intentionally co-located because what we're aiming to do with the model that we have at Whitman Walker is to really bring together both the clinical care side, the safety net delivery system and the FQHC, with research, policy, and education that really aims to leverage the experiences of our patients and communities for structural reform. Some of the things that we focus on in the work that we do include really working to name the problems. And I think we heard quite a lot about that from our conversations today, really calling out the systems that we have set up in this country and the ways that they work. Really something we can do, whether our role is as a patient advocate, as an educator, as a provider, as a fly that is attacking me. I'm sorry, they clearly know when I'm finally, when I'm speaking. We can really name the problems. And there's so much that goes on in the media and in politics of obscuring what's really going on, obscuring both the systems themselves, such as structural racism or anti-LGBTQI plus bias, and also obscuring the ways that they work to really affect, to really harm our health and well-being, both inside and outside of the clinic. So really naming the problems, and that's something that we do in our work around research, policy, and education in particular, trying to identify what is actually going on, and then translating those findings into improved, hopefully, interventions at the structural level with regard to workforce education, with regard to improving policies related to non-discrimination and other interventions. Some of the things that I want to highlight today, and I hope to talk more about these as we enter our conversation, but thinking about some of the priorities that we have as people who are really focused on making concrete progress towards health equity includes not just naming the problems, but also providing the data, the evidence in multiple formats that people can really engage with. I think as researchers, or as I'm a researcher, we often get kind of lost in the details, lost in the numbers, and don't really think about how to share the knowledge that we have, and remembering that data and research at the end of the day are really just stories. And that is such an incredibly powerful thing that we have as patient advocates who also wear other hats in our personal and professional lives. We have those stories, we know those stories, and treating those as something that can and should be shared, both in forums like this and with policymakers, with the media, with broader audiences, to really give a human face to what the research, the data, the evidence are showing us are the challenges. Then thinking about bodily autonomy, taking care of ourselves and supporting others. That's something that we're thinking a lot about in the health equity space right now, as there are so many attacks on abortion care, on other elements of reproductive justice, as there are so many attacks on transgender young people in particular as well. Thinking about what can we do to safeguard our physical, our bodily autonomy, and our ability to make decisions about ourselves, our bodies, our care, both inside and outside of clinical settings. And then finally, we do a lot of thinking around universal design, thinking about how when we're rebuilding a health system, or when we're reaching for health equity, how can we center the experiences of people and communities who have been most marginalized? Since as we're rebuilding systems, when we center the needs of people who have historically been pushed to the side, we can build a system that works better for them, but also works better for everyone. So very excited to have this conversation, Dr. Tucker-Seeley, with you and our colleagues here today.
So thanks, Dr. Baker, for highlighting the framework that you're using. I'd also like to highlight, the framework that we're using at my organization. So as I mentioned, I'm the Vice President of Health Equity at Zero, the End of Prostate Cancer. We're a prostate cancer education, support, and advocacy organization. And my role at the organization is a relatively new one. And so in my previous work as a faculty member at USC and also at the Dana-Farber Cancer Institute and the Harvard School of Public Health, I had taught courses around measuring and reporting health disparities. I'd worked with community organizations focused on, how do you implement a health equity strategy? And I came up with this framework that focuses on, the first step is, aligning the organization or the group on how do you define health equity and health disparities to ensure that everyone around the table defines the terms the same way. So that was one of our first efforts at Zero, was to come up with an organizational definition for these terms. Next is to highlight the specific health outcomes to focus on, because across, and I'll just use prostate cancer as an example, from efforts to prevention, detection, diagnosis, treatment, survivorship, and end-of-life care. There are a myriad of health outcomes where disparities are experienced that one can focus on. The other is thinking through where are you going to get the data to actually measure those differences, how those disparities are measured. So we as academics and researchers have multiple ways of measuring disparities, and those multiple ways of measuring those differences are not always clear to the community in terms of how we measure them. So being able to also not only measure the disparity, but being able to communicate that to the community members so that they understand those differences as well. And then thinking through what partners are at the table throughout this entire process, who's around the table to contribute to this process. And then, of course, to think about evaluation. What does success look like? Now, one of the things that I've realized that is missing from this process is an explicit focus on education and awareness. Those of us in academia and those of us that are researchers, especially those of us in public health, have been talking about social determinants of health, health disparities, and health equity for a long time. And I think oftentimes when we go out into the community, we assume that the community has been following along with that conversation, and they have not. And I think also, as was highlighted by our esteemed keynote speaker, we as a country don't know our history, especially the impact of slavery, which describes the pathway to the health disparities that we see today. So it's important that we not, look at these differences and say, oh, these differences, it's too bad we have them. We know Black people are going to do worse. I wonder how that happened. We know how that happened. And so they are the direct result of years of legislation and policy that explicitly discriminated against, disenfranchised, or completely ignored racial and ethnic minorities. So it's important that the education and awareness piece is a substantial component of the framework that we're working on that I've added to my framework.
That's such an important point, Dr. Tucker-Seeley, thinking about education and its role in equity, and not just education within the health sector, but also more broadly when we're thinking about, for example, some of the attacks on public education in the United States today. That is a concerted effort to undermine or erase our understanding, our knowledge of what has happened in this country. How did we get to be the way that we are? Because that ahistorical framework that is being pushed in so many corners of the United States right now, it's anti-evidence, it's also anti-history, ahistorical, the idea that where we are today simply came about as a result of no one's actions, and that there's no legacy involved here that we are still bearing the brunt of and bearing the weight of. And so I think thinking broadly about health equity too, not just as something that happens within the health system, but also involving all of these other sectors, really taking a social determinants approach that doesn't just ask, how do these other factors affect our health and well-being, but also our ability to even understand these frameworks or these systems that have and continue to oppress so many of us on the basis of factors like race or factors like sexual orientation.
Yeah, I agree 100%, and I think it's also important that we view these differences as unacceptable. I mean, I think there comes a time where we have to say that the differences that we're seeing, we're no longer going to accept them. And so I often get asked, why I left academia, and it was an environment that I held dear for a very long time, and I really enjoyed being a professor. And as a first generation college student, honestly, I could not have imagined that I would land in such a privileged place. But I will say that a part of that experience was continuously going to academic conferences, and I'll just use some cancer conferences that I would go to as some examples, and consistently walking out of those meetings hearing Black men doing worse, Black men do worse, Black men do worse, Black men do worse. And I think over time we just accept those differences. And so we have to say, as a society, as a group, we have to say that it's unacceptable that these differences exist, and we are actually going to disrupt the healthcare delivery system to create outcomes that look different than the ones that we've seen over the past many decades.
Yeah, I think that's a really important component of a definition of health disparities, right? Is that it's differences that are inherently avoidable and thus inherently unjust. that it's not simply a difference, it is actually a difference that should not exist, and that we have the capacity to do something about if only we care enough, if only we can be the types of catalysts for change within these systems I should say, to make those systems care enough, because I think we all care. We are here because we know the burden of these disparities on our communities, and we know that we want to build a better, more just healthcare system, a better, more just public health system, a better, more just world. And so the question is, how do we get that understanding that you so beautifully laid out of disparities being these differences that should not exist, that we as individuals and as systems, as a society, should not accept? And I wanted to ask you, actually, one of my favorite definitions of health equity comes from the Secretary's Advisory Committee for Healthy People, maybe Healthy People 2020, but they described health equity as social justice in health, which I really love, because it kind of, points us not at the disparities and the gaps, but points us towards that positive tension, that presence of justice. And I'm wondering if you could share some of the ways that you have defined in your work. You talked about one of the most important pieces of of working in an organization to actually define what is meant by health disparities and health equity, and wondering if you could share what those definitions look like for you.
Yeah, so one of the things that we did at Zero was, come up with what our definitions were for health disparities. And so our definition for health disparities includes differences between groups and health outcomes relating to preventing, detecting, treating, and surviving prostate cancer. So I think it's important in those definitions that you highlight, when you were thinking especially about chronic disease, that we focus along that entire continuum. Because thinking about, just the outcomes in sort of survivorship or in treatment won't necessarily, impact the substantial disparities that we may see in a population. And then for health equity, and I have to give a shout out to the American Cancer Society for their definition of health equity, which means that everyone has a fair and just opportunity to prevent, find, treat, and survive cancer. And we at Zero Cancer have adopted that definition, that health equity means that everyone has a fair and just opportunity to prevent, find, treat, and survive prostate cancer. But we've also added that this requires removing obstacles to a usual source of healthcare. So for prostate cancer, as an example, you generally will start your process with a primary care doctor, but not everyone has a primary care doctor to get the necessary screening that then gets you to specialty care. So what is necessary for not only for the implementation of health equity is that those obstacles to the usual source of healthcare, coordinated high quality specialty care, and ensuring that families have the resources that they need to manage and navigate the primary and specialty care delivery system. So if I put my researcher hat on, my program of research is focused on financial hardship and cancer. And so often, cancer specifically, but chronic disease generally, can be financially ruinous to a household. And so people will avoid the healthcare delivery system, for fear of financial disaster following that. So health equity, that's a very long answer, but that is sort of how we are applying our definition of health equity at Zero.
I think that's really fantastic. Yeah, and that's something that we think a lot too, just to your point about primary care. As a safety net provider, as a federally qualified health center at Whitman Walker, we think a lot about how to implement a no wrong door approach, so that no matter why someone is coming to us, whether it's for an HIV test or for mental health, or just because they needed a checkup, and we're fortunate, we were able to make sure that they knew that our doors were open before they ended up in some place like the emergency room. But regardless of why they come to us, that they can then be linked up with a whole suite of services, dental services, mental and behavioral health services, a whole range of primary care, sexual health services, and really sort of trying to think about that ability to integrate services such that we're not asking people to make these it really frustrates me, both the conversations around skin in the game for patients in our healthcare system and the informed consumer, because we all know that healthcare is not like other markets. It's not like other places where you're not shopping for a car. You're really trying to make pretty hard decisions, often scary decisions, with really a bare minimum of information. And so trying to make sure that no matter where people come to us, that we can then enfold them with a whole suite of wraparound services that will help them navigate these different components of the health system. And I want to highlight two components of the services that we have that really try to get at that, the education and navigation piece. One is our medical legal partnership. Whitman Walker has the nation's oldest medical legal partnership. So we have a public benefits and insurance navigation team that works with individual patients on everything from name changes for transgender patients to immigration filings, to working with insurance carriers to try to figure out how to navigate this incredibly complicated system of coverage that we have in the United States. And we also have a gender affirming care navigation program, which is where we help people. We serve thousands of transgender and gender nonconforming people every year. And our gender affirming care program really tries to help people identify what is the next step in their journey and how can we support them, not just with the primary care and mental health services that we provide at Whitman Walker itself, but navigating again through these really, really complex systems. And we really think of that as a core principle of equity, really making services, concrete services, tangibly accessible to people, again, no matter what door they enter our clinic through.
Yeah. So, Dr. Baker, you made a statement that it's reminding me of the time that I spent in Washington when you said that, oftentimes when we talk about patients, we want them to have skin in the game. I once heard a patient advocate say, when I'm navigating the healthcare delivery system, my skin is the game. Like I am navigating this system with trying to navigate this system with my whole self. So thanks so much for sharing sort of all of those programs. I'm curious how, based on Isabel Wilkerson's mentioning of radical empathy, how you're going to take that back to your organization. Is it already a part of your organization? And after your comments, I'm happy to share sort of how I'm thinking about it in terms of the way in which I hope we implement it at Zero.
Yeah, I mean, it's definitely a principle that we aspire to. We're all, as folks working in a safety net environment, trying to think through, how do we understand both our roles as professionals in this space, but also our roles as patients, as advocates, as community members, and really, that veil between us, between patients and providers that's so often present, how to make that disappear and really how to embody, again, all of our identities, no matter what role we're playing, and actually looking to meet people not just as a service provider, but as someone who is there to listen to every element of their experience, to respond to every element of their identity, and to really be, again, not just a service provider, not just somebody who is trying to help people navigate a particular system, but also recognizing that we are walking through this with them. And what does that mean to truly be present and to not kind of go back, try to fall back on relying on a professional hat and sort of saying, well, I'll do my best, but I'm not, at the end of the day, that there's some elements of your experience that I simply can't understand. There will always be elements of people's experience that we cannot fully fathom, just because of every one of us has different experiences as we move through this world. But really using every encounter with people that we meet, that we serve, that we walk with in community, to make porous that boundary that so often exists, and really be present and listening and with people, not just sitting behind the computer. I mean, I'm thinking about what it looks like, in a healthcare encounter where there's the person literally, the provider so often behind the computer, and really, but like how to take those barriers down and how to really understand our common experience as human beings. But I would love to hear more too about how you implement that at Project Zero.
Yeah. So I found this quote from the book or from Isabel Wilkerson about radical empathy. And it says that radical empathy means putting in the work to educate oneself and to listen with a humble heart to understand another's experience from their perspective, not as we imagine we would feel. Radical empathy is not about you and what you think you would do in a situation you have been in and perhaps never will. It is a kindred connection from a place of deep knowing and opens your spirit to the pain of another as they perceive it. Empathy is no experience substitute for the experience itself. We don't get to tell a person with a broken leg or a bullet wound that they are not in pain. And people who have hit the caste lottery are not in a position to tell a person who has suffered under the tyranny of caste what is offensive or hurtful or demeaning to those at the bottom. The price of privilege is the moral duty to act when one sees another person treated unfairly, and the least that a person in the dominant caste can do is not make the pain any worse. So it's important that we think about, based on the comments that that Ms. Wilkerson made today, that empathy is a process. It is work. It is more listening than talking. So one of the things that we have at Zero, the End of Prostate Cancer, that we've recently initiated is a project called Prostate Cancer in the Black Community Film Series. And this is a film series that includes 2 documentaries and 1 documented drama of 2 brothers navigating their prostate cancer journey and sort of what happens when one gets green and one doesn't. And we have found that this is using film to highlight, one's experience with the healthcare delivery system. I think it is one way that we can actually see, how someone who may or may not be part of our group is experiencing the healthcare delivery system. And what we found is that, we often hear that men don't want to talk about their health, and especially Black men don't want to go into the healthcare delivery system. There are some reasons due to the healthcare delivery system not always being trustworthy partners to us, but it's important to, what we have found in this context, that once we show the film, the conversation just opens up around barriers and sort of barriers that other people have experienced, and sort of talking through the ways to, sort of navigate those barriers, but also thinking through what can we do to change the system so that those barriers no longer exist for the next group of people that will have to navigate it and manage their prostate cancer journey.
That was such a beautiful quotation that you read from Ms. Wilkerson. I can't believe you asked me to try to define radical empathy before you really just hit me with the real, the beauty of her words and the ways that she describes this. I mean, this is the common challenge that we all have of recognizing the different points of privilege and different points of power that we all have, and trying to figure out how do we check the privilege at the door while also taking opportunities to recognize where we do have power. As a white man, I certainly have power in very specific ways in our society. And I'm also queer and also transgender. And so that really makes, in many ways, my attachment or my ability to access different sources of that type of social privilege conditional, and really, affects sort of the ways that I navigate through the world and through the healthcare system, these different elements of my identity. And so trying to think through, where are the points where I need to be listened to, where I'm trying to share something about my experience with somebody who may be in a position to help me. And then also, where are those opportunities where I have the ability to, as you were, pointing out in your work and in that quotation, where I have the ability to listen and really take in the experience of another person, and without co-opting it, without trying to make it about me, how do I identify those sources of power and ways to use the elements of privilege that I have within our social system, within our healthcare system specifically, and trying to acknowledge myself, as a person with a whole bunch of different identities, and also a person who can and needs to leverage elements of those identities to make change, to challenge the system, to advance health equity in really, really concrete ways that actually tangibly benefit people that I'm working with or people in my communities.
Yeah. Your sharing of your identity sort of reminds me of a statement that I often say in terms of my own personal navigation of the healthcare delivery system. I often think what do I need to wrap myself in to be seen as a person? I learned early that my gender, and then within that, how I meet the expectations of my gender in terms of behavior, my race, and my socioeconomic status influences consistently how people interact with me. And so my own experience in navigating the healthcare delivery system is really highlighted by what I choose to wrap myself in. So the example I often give is I was a first generation college student. I had the great privilege of going to Harvard for graduate school. And so when I got there, I was so excited. I bought so many t-shirts and sweatshirts and just was sort of wearing them all the time. And I wore one of those t-shirts to a healthcare appointment. And I realized that people treated me very differently when I was wearing a Harvard t-shirt. So it would either be someone would ask, oh, who do you know that went there? And then you say, I'd say myself. And then all of it, there's a different look that they give you and different ways that they talk to you. And then when I was a professor, always making clear to the healthcare provider that I was a professor that did research in public health and healthcare delivery. Again, that changed how they interacted with me. And we can't wrap everyone in those things to be seen as a person. So it's important to think about. I loved your statement of sort of thinking about where I have privilege and how can I use that, but also thinking about the ways in which or the things that we need to be seen as a person as we're actually navigating the healthcare delivery system.
Yeah, and the degree to which those things, some elements of identity are clearly visible and some are not. And that complexity of navigating disclosure, of navigating, that feeling of, is this going to be a safe space for this particular element of my identity? And then those components of our identity that we don't have those choices about in terms of whether we're able to enter a room, a healthcare encounter without having the sort of expectations that come with different types of identity automatically attached to us. And I think that is something too, as we're thinking about the experiences of patients and ourselves as patients, ourselves as advocates within the healthcare system, trying to think through the ways in which we can support people in navigating those complexities of disclosure, of understanding, where are the different elements of me that are showing up that can be easily attacked, and are sort of the very clear targets of oppressive systems. And then also, where are the ways in which many people who have unmarked aspects of identity that are often targeted, for example, different types of disability, how are we supporting people in their choices or their abilities to make different elements of those experiences visible versus feeling like they have to hide in order to be seen as a whole person, and it's sort of the very complex dance that attends to all of these different, or so many of these different elements of our individual identities.
So I see that we probably only have about a minute left. So I think sort of giving our closing remarks, and my closing remark is really focused on I hope that we don't have what I'm terming health equity fatigue, in terms of, I'm hearing a little bit of folks say, oh my gosh, we're still talking about health equity. We're still talking about health disparities, but we have yet to fix them nor achieve health equity. So yes, we are still, talking about these issues. So I would just, encourage us all to take a breath and continue the fight. And then the second thing is this notion of radical empathy, and really sort of subscribing to the notion that Isabel Wilkerson presented to us around radical empathy and our engagements with each other.
I love that. And the only thing that I can add to that, with regard actually to health equity fatigue, one of the reasons that I love health equity as a framework, and think that it's really an advance in our thinking beyond health disparities, is because health disparities is everything that's wrong. And it's very easy to get mired in that. And it's very easy, I think, to feel dispirited and really sort of be thinking, are we still talking about these disparities? Are we still talking about all of these ways in which our people and communities are being harmed systematically and unjustly? But health equity to me is the dream. It's the future. It invites us to be creative. It invites us to dream. It invites us to think about what are the ways that we want to see systems look different, act different, and provide different outcomes for individuals and for communities. So to me, health equity, I kind of try to hold it as a prism, or as, something beautiful that helps, you hold it up and you can see all of the myriad opportunities or different approaches that we could take to building better systems, and using that, less as a sort of goad through the journey, and more as this shining opportunity to dream about what the goal can be.
So I think we'll hand it over now to Gwen.